teachers, professors and seniors. Today I'm going to present a case report about chronic tuberculous tenosynovitis of the hand. And we see that India is burdened with tuberculosis, and it is endemic to tuberculosis. And in 2022, the report says that about 2.24 lakhs of people have been affected by tuberculosis. So the burden in our country is more. And if you see the types, basically it is categorized into pulmonary and extrapulmonary. And talking about extrapulmonary, about 5% of the cases of all the tuberculosis belong to the musculoskeletal form of the tuberculosis. So by meaning musculoskeletal, we mean that it is involvement of the bone, joints, tendons, tendon sheaths and muscles. So why I want to present this case is that usually the patient comes to us late, and there's always a delay in the diagnosis because the patient has vague symptoms and he himself will reach the hospital very late, and there are some diagnostic challenges, and awareness about this particular condition, especially in our country, is very important. Coming to the case presentation, when the patient came to us initially, he came with the complaints of ulcer at the base of the left little finger. But on for the past 2 months, but on asking him for the questions that how it started, he came out with a history that he had a swelling before that itself, but 2 months before even he developed an ulcer. This is a picture which was taken from his mobile, and he has shown us this picture. So basically, the 2 months he had been having this swelling, it didn't disturb him at all, and he didn't have much problem in doing his routine works. But when it developed as an ulcer, only then he came to us, and he had other associated issues like some mild dull aching pain at the finger, and he's unable to move his little finger. And on further eliciting the history, we could even, there was no history of any paresthesia or numbness, and there is no history suggestive of any tuberculosis or no history of any contact with tuberculosis, or he himself is not having any issue, any tuberculosis. So on examination, if you see, first about the ulcer, it is about 1 into 0.5 centimeters at the base of the left little finger. We can see that there is some edema around this area, and there is some fullness in the hypothenar eminence, which the patient hadn't described to us at all. But on palpation, if you see, it is actually a swelling which is about 2 into 2.5 centimeters, which is extending up to the distal forearm. And this swelling was soft. Though we couldn't elicit any cross fluctuation, some amount of fluctuation was present. Apart from that, there was no movement of proximal interphalangeal joint, distal interphalangeal joint, MCP joint, but some amount of restriction of movement at the wrist flexion because of the swelling. And there is no history of paresthesia or numbness, or no history of any loss of movement with the other fingers. On examination also, the movement of other fingers were normal. So immediately we asked for an X-ray, and in X-ray we want to rule out if there's any involvement of the bone, and there is no involvement of bone, and we can see that there is a soft tissue shadows in this area. And at this particular stage, we had a diagnosis in our mind of either chronic tenosynovitis. It can be of any etiology like tuberculosis or fungal or any other bacterial chronic tenosynovitis. And second differential diagnosis was giant cell tumor of the tendon sheath. So immediately we asked for an MRI. We skipped the ultrasound because anyway the MRI is going to be a definitive investigation. So in the MRI, there are 3 views here. One is the coronal, the sagittal and the axial view. In the coronal view, we can see that there is a thickening of the synovial sheath surrounding the FDS and FDP tendon, which started in the forearm. It is extending below the carpal tunnel and into the hand and going to the little finger. And in the sagittal view, we can see that there are multiple hypoechoic lesions within the tendon sheaths. There are hypoechoic lesions within the tendon sheaths. They measured about 5 to 13 millimeters in diameter, and this is a tendon sheath, and inside the tendon sheath these nodules were present. And this is the axial view showing the same, like nodules within the tendon sheath. And MRI also showed that there was compression of the median nerve in the carpal tunnel, though clinically the patient didn't have any symptoms. Then we wanted to rule out tuberculosis, so we did CBC, ESR, MAN2, and X-ray chest to look for any primary, and all the investigations were normal. Then we went ahead, we planned for a procedure, first to explore and then proceed. So we did investigations required for the surgery, and these are the operative details. Under supraclavicular block, the markings were made. We initially marked the zigzag incision up to the forearm. We first gave an incision at the base of the little finger, and after opening, we saw that the tendon sheath of the FDS and the FDP was thickened. And next we opened, we made the incision at the level of the carpal tunnel and the forearm. Here also we can see that there is thickening of the tendon sheath of the FDS and FDP. So this is a reason for the median nerve compression in the carpal tunnel. Then we completed the incision, and we can see that the whole of the tendon sheath involving the FDS and FDP of the little finger has been thickened. And once we opened the tendon sheath, we were able to see that there were yellow glistening granules. These are the yellow glistening soft granules. So these are called as the rice bodies, which are the characteristic features of tuberculous tenosynovitis. So this is the excised specimen where we have excised the tendon sheath, and from within the tendon sheath we have removed these rice bodies in a piecemeal manner. The tendons were intact, and we send the specimen for the histopathological examination, and it shows that there are Langerhans types of Jane cells, necrosis, Langerhans Jane cells, then epithelioid cells, and granulomatous inflammation. So all these features were suggestive of tuberculous etiology. Further, we sent even the sample to the CBNAT to test to confirm the diagnosis of tuberculosis. So it came to be Mycobacterium tuberculosis positive. Then with all this area of investigations, we sought an opinion from the pulmonologist, and the patient was immediately started on the ATT. So initially the treatment has to be given for 2 months, 4 drugs, and then followed by three drugs for 7 months. So isoniazid, rifampicin, ethambutol, and pyrazinamide for 2 months. Isoniazid, rifampicin, and ethambutol for 7 months. And usually at the end of 6 months, we have to check for the response. If the patient is responding well to the ATT, we have to continue this treatment mandatory till up to 9 months. Or if the response is slow, we have to continue even up to 1 year. Post-operatively, the scar was well, this is actually 3 months post-operative, and the scar was well settled, and he only had partial recovery of the movements of the little finger, and he's still under our follow-up, and we'll be following him up for next 1 year to look for the full recovery of the movements of the little finger. Now coming to the tuberculosis involvement of the hand, usually there are 4 types of tuberculosis involving the hand: the cutaneous tuberculosis, the tuberculous tenosynovitis, tuberculous arthritis, and dactylitis. So we should know about tuberculous tenosynovitis, as these patients come to the plastic surgeon most commonly. By definition, it is an inflammation of the tendon sheath and the synovium, and it was first described by Arsen in 1777. And rice bodies were described by Rees in 1895. The most common form of involvement of the tendon sheath is through hematogenous spread, whether the patient is symptomatic or asymptomatic. The next common cause will be by the direct spread, and isolated cases of synovitis alone is very rare. As these patients come very late to us, and they are more prone for complications like involvement of the bone, adjacent joint, or rupture of the tendons. Predisposing factor, just like any other tuberculosis patients, like malnutrition, low socioeconomic status, alcohol, steroids, immunosuppression, and overuse of the joint and hands, or trauma are the predisposing factors. If you look at the pathogenesis, there are usually three stages of this disease. One is hygromatous stage, the serofibrinous stage, and the fungoid stage. Hygromatous stage is the early stages where the disease will only form fluid collection within the synovial sheath, and the synovial sheath is intact and it is not thickened. In serofibrinous stage, as in this case, there are fibrinous exudates which later detach from the wall of the sheath, and they deposit fibrin and collagen, and they form rice bodies. So this is serofibrinous stage. Next is fungoid stage. It is an advanced stage where when the immunity is low for the patient has multiple caseation necrosis. There is sinus formation and ulceration formation, tendon rupture, and involvement of bone and joint. Clinical features, as in this case, usually patients come to us late. They have vague symptoms, progressive swelling, which is slow growing, some mild or vague pain, and with decreased range of motion. And in later stages, they have sinus tract formation or ulceration. And if the swelling is large, then they may compress the median nerve, and they form. The patients may complain with complaints of paresthesia, numbness, with median nerve compression. Then lesional lymphadenopathy because of tuberculosis itself or because of any secondary infection, and associated symptoms of tuberculosis like fever, loss of weight, appetite, and night sweats. Investigations, as usual, we have to do all the routine investigations and rule out any primary focus for the patient. And imaging, first is X-ray. In X-ray, we have to look at any osteomyelitis or any osteopenia because of the chronic swelling which is compressing the bone. In ultrasound is not confirmatory, though it says that there is thickened synovium, there is fluid in the synovium and extent of the disease. The MRI tells more details about this disease. In MRI, as we saw, there is thickening of the synovium. There are multiple rice bodies which are seen as nodules within the synovium, and if the tendon is intact or not, that can be seen, and if the nerve compression can be assessed, and if the disease goes beyond the tendon sheath, that can also be assessed through MRI. But again, even after MRI, we have so many differential diagnoses. So the same type of picture can be seen even in giant cell tumor of the tendon sheath. So histopathological examination is the confirmatory test where it shows Langerhans giant cells and granulomas. Moreover, we should rule out other causes also. The tissue which we have taken, we have also sent for bacterial culture, fungal culture, along with tuberculosis, and other causes for tenosynovitis was ruled out. And CB-NAT is a confirmatory test which which nails the diagnosis of Mycobacterium tuberculosis. Differential diagnosis, the chronic tenosynovitis due to other causes like fungal tenosynovitis, bacterial tenosynovitis, or giant cell tumor of the tendon sheath, rheumatoid arthritis, and other mycobacterial infections. Treatment of choice is always medical, with or without surgery, for chronic tuberculous tenosynovitis. So not all patients are candidates for surgery. ATT is a treatment of choice. So when do we go for surgery? If the swelling is so large and the burden of the disease is huge, and there is no response to the medical treatment, or associated with nerve compression, or associated with any other secondary infections. So I would like to conclude that chronic tuberculous tenosynovitis is a rare condition, but it should be always kept in mind in countries like India, where the tuberculosis is endemic. And delayed diagnosis is because the patient comes to us very late already, and and the symptoms are very vague, and we have to investigate him properly to arrive at the diagnosis. In our case, the patient is healthy individual. He's 26-year-old. He doesn't have any comorbid conditions, but still he had the tuberculous tenosynovitis. So therefore, we should, in the back of the mind, we should always keep it in mind that even healthy individuals without any immunosuppression or any other associated diseases, it is possible that they are prone for developing this disease. Early treatment is always good to prevent any complications, whether we are doing medical therapy or combined with surgery. So usually in late stages, the complications like secondary infection, involvement of the bone, joint, or arthritis will happen. Therefore, early treatment always gives better recovery and restores functions in the patients. And follow-up is mandatory for 3 reasons. One is that we have to assess whether the patient is sticking to the ATT regimen or not, whether he is having compliance or not. And second thing is we have to look at the response to the ATT. And third thing is after completion of ATT, there's always some recurrence. So we should monitor even after completion of treatment. We should follow up with the patient and look for recurrence of the disease. We recently published this in a journal called Curious 2 months back. Thank you.
Thank you, Dr. Kanchana. Nice presentation and excellent result. Any questions for Dr. Kanchana?
Yes, Dr. Kanchana, it was a very nice presentation.
Thank you, sir. Thank you, sir.
I want to confirm, what was the tuberculosis? Where was the tuberculosis? You must have investigated the patient
Yes,
already
sir.
about the
Yes,
chest
sir.
and
Yes, sir.
where was the primary lesion? It was the chest, pulmonary.
So this patient didn't have any primary lesions, sir. He's a healthy male and he didn't have any primary lesion anywhere. Even after assessing, we had done chest X-ray, we had done MAN2, and ESR was normal.
That
Everything
was
was
I was
normal.
saying.
Yes, sir.
So I could not find anything in the investigation that could give a clue about the pulmonary or like that.
Yes, sir.
And one thing I want to add, that very important differential can be the giant cell tumor also.
Yes, sir. Yes, sir.
Plus I have seen one sarcoid.
Yes, sir.
Sarcoid of the hand, maybe both are rare. Tuberculosis is also rare. Sarcoid is even more rare. But
Yes, sir.
sarcoidosis and sarcoid lesions in the digits,
Yes, sir.
almost presentation is same.
Yes, sir.
So sarcoid is another differential which should be kept in mind if there is a tenosynovitis. Sarcoid tenosynovitis is another
Yes, sir.
entity
Yes, sir.
which actually happens when you deal with the animals and all that
Yes, sir.
in the rural areas, and we have seen that.
Yes, sir.
That came to my mind, that sarcoid can be another differential diagnosis apart from the giant cell. Thank
Yes,
you.
sir. Yes. Thank you, sir.
Thank you, Umar sir, for your inputs.
Thank you, sir.
Any other questions for Dr. Kanchana? Thank you, Dr. Kanchana. We'll go to the next presentation, small change in presentation. Dr. Shivaram Bharadwaj will present on preliminary report on LBA technique, immediate post-mastectomy. You have to stop sharing, Kanchana.
I'll stop sharing, sir.
Thank you.
Stop sharing.
Yes, sir.
Can you see my
Yes, sir.
screen
Yes.
and can
Yes,
you hear
sir.
my voice?
Yes, sir. Loud and clear, sir.
Yes, go ahead.
Loud and clear,
Yeah.
sir.
Okay, great. Okay, good morning, everybody. Thanks for giving me a chance to do this. So, in this brief report, I'm just sharing some of